can you just talk a little bit more about how these drugs compare to each other and maybe a situation in which one would be more desirable over another?
The comparison with warfarin is a very important conversation because there's not a one-size-fits-all strategy with those particular therapies. There's going to be patients for whom each of those is a very legitimate option. The attractive portion of the anti-10A drugs, or the NOACs as they're sometimes abbreviated, the novel oral anticoagulant compounds. 2 hours after you take the first dose, you are anticoagulated. And so the bridging and the dose measurement, that you don't have to go for INR monitoring, and all of those things are very attractive. But the price tag is about $10 a day. So with warfarin, you're going to have the INR monitoring, you're going to have the dosing adjustments, you're going to have drug interactions that are a possibility. And one of the things that folks tend to overlook in the warfarin conversation is that in their clinical trials compared with the NOACs, the average time in therapeutic range with warfarin was about 66%. And so you can look at that one of two ways. You can say, you got 66% and you had similar outcomes. Or you can say you only had 66% of the time that you were in control. And so if you could bump that up to 80%, how would the outcomes that showed they were not inferior to each other in clinical trials manifest in terms of an individual patient conversation? The NOACs also have the risk of bleeding, and the reversibility of that bleeding with warfarin is what some people perceive as an attractive thing. There are reversing agents becoming available for the NOACs, but they're very expensive. And in many cases, because of their short half-life, you can just, at most, maybe transfuse somebody a unit or two of blood, and then the drugs will wear off and everything will be better. But the cost associated with GI bleeding is definitely something that has to be taken into account. But the ability to have the consistent control with those drugs also makes them a very attractive option. Health systems pharmacists' role in this situation, it is so important that with the NOACs, that compliance is consistent because the drugs go away quickly. And so if you have somebody that's on a once a day or twice a day dose of one of those medicines, and they run out of their medicine on Saturday and don't think they're going to go to the pharmacy to get it refilled until Monday, that's a bad thing. If they have atrial fibrillation, they very well could have a stroke on Sunday. And we don't want that to happen. And so it's imperative that we have a level of communication and access for the patients established in order to predispose them to success with this very important therapeutic tool trying to stave off the ravages of stroke.